Hello everyone. Today I'd like to reach out to people all over the world about the importance of doing the risk assessment for blood clots, for thrombosis. This is really crucial now in this era of the COVID-19 pandemic because of the fact that this disease is associated with a very heavy incidence of venous thromboembolic problems. We know that fatal pulmonary emboli are the #1 preventable cause of death in hospitalized and surgical patients. We also realize that appropriate anticoagulant prophylaxis can prevent most deaths. Risk scoring identifies who's at risk for these emboli and guides the physician choices for preventative measures. It is important to provide prophylaxis for the entire period of risk, and that's the key to preventing these deaths. You just can't do it, for example, during the hospitalization. Many patients need ongoing prophylaxis when they go home, either because the hospitalization was short or because the risk persists even after a relatively long hospitalization. That's particularly true with the COVID-19 virus. Now, we all have unique baggage that we carry with us everywhere we go. And that's a unique set of risk factors that makes a person prone to develop a venous thrombosis. Things like obesity, cardiac or pulmonary disease, cancer, family history of blood clots or stroke, diabetes, hormone therapy, etc. A risk score can be calculated based on these risk factors that is predictive of a thrombotic event if surgery, injury, or illness occurs. Knowing one's baseline score is an important part of their baseline medical record. Informing healthcare providers with this personal information is critical, especially if one contracts the coronavirus, experiences a disabling stroke, or requires emergency surgery. Suppose you're brought to the hospital unconscious. Well, the family members would be able to provide your input score. Another problem is that sometimes these hospitalizations are very hectic. A person is very sick. They require a lot of interventions. That's no time for somebody to sit down and ask 40 questions. It's good to have a lot of that information there available to make the healthcare provider's job a lot easier. Now, what is the Caprini score? The Caprini score is nothing more than a good history and physical. Is it the only road to Rome? Of course not. There are various risk scores out there. There's some very good ones that have been tested, and if you have a particular risk score that you like better, that's fine. We like the Caprini risk score because it's the most comprehensive evaluation of the patient's risk factors, which then we feel the more you know about the patient, the more likely it is that you'll be able to predict an outcome such as a venous thromboembolic event. So we know that the more risk factors you have, the higher your incidence of thrombosis. That's been known for a long time. We also know that each risk factor has a certain power to cause a blood clot. Some are not too powerful, like bed rest or hormone therapy. Others are very powerful, like cancer or history of venous thrombosis. So the power has to be combined with the number, and that gives a statistical calculation that results in a simple score. And that score, that number, has been evaluated in 5 million patients around the world, and here we see the results in general surgery. There is a nonlinear correlation between the score going up and the risk of venous thromboembolism going up. Now, it's very difficult to evaluate 40 factors, and for a long time that was an impediment in people using this score. But a lot of bright people came up with a patient-friendly version of the score, and that's really helped immensely. Just think of it. When you go to the dentist, you have to fill out your health history before the dentist will see you. Well, the same thing holds true here. Involve the patient in their care. Patients love getting involved in their care. And what you need to do is you need to do your score. And it's been done in a variety of languages. It's very straightforward. It can be filled out relatively quickly, especially if you do it with your loved ones who can help you for questions you may not have the full answer to, like family history and so forth. And then this score captures 40 elements, and using this patient-friendly version, huddling with your loved ones, you can come up with a score, and then it can be validated by your personal physician. Then once you have that, you can keep it as a part of your medical record and also give it to your family members as a part of your medical record. And that's the most important thing, having loved ones aware of this baseline score. The baseline score can then be presented by the patient or family members to a healthcare provider during an injury. Even if you're an outpatient and you require a cast you may not be aware of right away, but you should tell that doctor about your score, because that may influence your chance of getting prophylaxis. You may need prophylaxis if your score is high. But if you develop, for example, the coronavirus, even if you're at home and you get tested because somebody in the family developed it and you're found to be positive, then you may need prophylaxis actually at home with anticoagulants. I'd like to stop for a minute and talk about immobility. Now, this is a well-known risk factor, but often poorly understood. For example, I've seen it in many hospital systems that they have a requirement that if the patient becomes ambulatory, they don't need anticoagulant prophylaxis anymore. Or the doctor that says, well, if you just get up out of bed, you'll be protected against blood clots. That's only good up to a certain point. Mobility is only good to reverse the risk factor of immobility. So, for example, if the patient has cancer, has a serious infection, has just had a big operation, that even though they may be able to get up and walk around, the rest of the baggage that they have with them stays with them. So they're still at risk. They still need prophylaxis. The risk is a little less because of mobility, but just a little bit less risky. Well, what is immobility? How do we evaluate it? I don't really know the answer to that question, but I would say that the best information we have available and what we've adopted for the Caprini score is the definition coming out of a trial that's 20 years old called the Venous trial. In that trial, people from around the world were randomized either into getting low molecular weight heparin or not when they were in the hospital and at risk for getting a blood clot. And of course, it was very successful. It showed that the patient should get low molecular weight heparin, and that lowered dramatically their incidence of a blood clot. Within the population that didn't get prophylaxis, a subset analysis was done by Al Peshameen, a brilliant young man, and he and his colleagues showed that if the patient was unable to walk 30 feet at one time, that their incidence of DVT was 19%. But if they could walk 30 feet, it was cut in half to around 10%. So that relative risk reduction of 50% was very significant, and that's what we use to gauge ambulation. So if a patient is using a cane or a walker to achieve that goal, that's fine. They're still ambulatory. But, however, patients sitting up in a chair or walking a short distance to the bathroom, that doesn't qualify as ambulation. And furthermore, if the patient has a leg cast boot or brace that inhibits the normal calf muscle action in one leg and the foot flexion action, that patient's immobile. And if the patient can't weight bear, studies have shown that the blood flow in that leg does not increase, so no amount of walking with the other leg protects that leg. That leg is at risk, so that patient is functionally immobile. This is very important for you all to understand. Now let's turn to specific scoring during the coronavirus pandemic. Based on some evaluation by a number of us, we feel that the positive patient who's asymptomatic should be scored an additional 2 points. If they are symptomatic, add another point, and if they have a positive D-dimer, we would increase that score to 5. Because we feel that patients that have a positive D-dimer, symptomatic with the virus, are very much at risk as somebody who'd had a past history of a thrombosis, or more, actually, or more. And we also realize that this score needs to be updated during hospitalization. For example, patients need to be reoperated. They may have infection. They may develop perforation. They may have central lines. They may need further treatment because of a cancer that was not diagnosed. And all of these things may cause an increase in the score that may change the amount of prophylaxis that the patient is getting. So this is really a dynamic instrument. And the most important time is not only before and during hospitalization, but when the patient gets ready to go home. So let's talk about what the American Venous Forum has put together for suggested guidelines. And all patients with a coronavirus should receive heparin or low molecular weight heparin prophylaxis due to the high risk of thrombotic complications. And as I said, that may be at home. This virus induces an injury to the lining of the blood vessels all over the body. Now, the Caprini score quickly identifies and quantifies the comorbidities that the patient has. And if the score is over 8, then they ought to get double the normal thrombosis prophylaxis. Or if they have an elevated BMI, heart failure, positive D-dimer, past history or family history of thrombosis. Now, at discharge, it's very, very important to rescore the patient and use extended chemical prophylaxis for scores of over 8. Again, elevated D-dimer, BMI of over 35, limited ambulation, heart failure or chronic obstructive lung disease, history or past history of venous thrombosis. These are all things that should cause a person to be given prophylaxis after discharge with COVID-19. But now let's step back in history. 2008. We know that patients that were discharged from the hospital, that 77% of them got a clot after hospital discharge and 55% after their anticoagulants were stopped. We know this information from the wonderful work of Monreal in the Riete database, as well as my former fellow Juan Arcelis, who I had the privilege of having for 3 years and did an enormous amount of research in our laboratories. Now, that was in 2008. Well, now, what about now with the coronavirus? It's even more important to score these patients and to give them post-discharge prophylaxis because of the coronavirus. And I would emphasize to everybody that they ought to know about this and ask their physicians about this. So in conclusion, ladies and gentlemen, perform risk assessment using the patient-friendly version assisted by your loved ones. Share the results with your family doctor to verify your final baseline score. Save the results as a part of your medical record that other family members can access. Remember, if you develop COVID-19 as an outpatient, anticoagulant prophylaxis may be appropriate. Ask your doctor about continuing anticoagulant prophylaxis after you survive the illness and are discharged. And remember, never kill a friend, never treat a stranger. What we mean by that is that by performing a thorough history and physical, you have knowledge about yourself or the patient, if it's the doctor, as if they were a good friend. And, of course, you would never treat a stranger and you would never hurt a friend. So, folks, it's your responsibility to begin with to capture as much of this information as you can right now, today, and have that ready should you get ill, and also present to your doctor in case of anything happens. So in summary, I'd like to thank you for your attention, for listening to this presentation. Please visit my website at venusdisease.com for more information, or my YouTube site at Venous Resource Center. And everybody, please, when you finish listening to this, go get a pencil and paper, fill out your risk assessment, share it with your doctor, and please stay safe and have a wonderful day. Thank you very much for your attention to this presentation.